I'm like, listen, you don't have to eat, this perfect diet, and it's not all about calorie restriction. Here's the balance. It's been so good. And as I've been leading their pilot, I feel like it's been great for me because I created that new program because I've been doing a lot of different programmatic work for hospitals. And I was like, I'm going to create my own because, versus doing it. And I was like, all right, so that's the baby. So that's my shift program. And then because I coach-led all the pilots,
Good morning,
I was like
everybody.
boots on the
As you
ground going,
are
we need to add that, tweak that, make sure people understand that.
I want to entertain you in
right?
the next few minutes with talking about an important topic that you are all very familiar with. As just now you heard from Wendy, we have been using palbociclib in the treatment of hormone receptor positive, HER2 negative metastatic breast cancer for 10 years. So my name is Sramila Aithal. I'm a medical oncologist and hematologist working at a U.S. oncology practice in Northeast Philadelphia and special interest in breast and gynecological cancers. So before we proceed further, it's a very small group, and although I don't know most of you, but I'm hoping that you are outside of Sedona, and I wanted to see if you can hit me with some of the cool things that we do not know about Sedona. Anybody daring? Because I learned at least 2 things this trip, so I was going to share with you. So anybody daring to share with me some unusual things about Sedona? Go ahead, I hear a hand raised.
There's Montezuma Castle. I think I'm saying it right because it's like we'll see it. It's not that far. And then I think it's a Duke's structure down the street. So those are good sites to go to.
Awesome. That was one of the things that I was going to share with if nobody answered. Yes, I just learned about the missing of Sinagua. Apparently, that community or tribe lived here for centuries, and they were really unsophisticated. I mean, they were doing a lot of cool stuff, including trade, and had pets with them. And then after centuries of living here, I heard one day they disappeared from here, and that's called the Great Abandonment. And that's what we saw when we drove from Phoenix to here, Montezuma Castle. That was cool. Any more? An additional tip? Yeah. Uh-huh.
I just moved to Phoenix in November, so we've been there twice. But there's like a little hiking trail, and there supposedly is like a vortex over the Aithal.
Yeah, Airport Mesa. Cool. Thank you for that. Thank you. So, and it's also, I know of the best place to watch sunrise and sunset, Airport Mesa. One more. Yeah. Let's hear. One stoplight? Ooh, that's cool. That's good to know. One more. Oh, thank you. That's awesome. And I was going to end with just one last one. I learned about, as we drove by, we saw McDonald's. And have you ever noticed that the M of McDonald's is in a turquoise color and not the usual golden color? So apparently this is the only place in Sedona in the world where McDonald's has a different color, and I learned because a golden beam will reflect, and that's why they chose to have a different color, which will probably have a better background against the red rocks. So with that, let's get on to some serious stuff. That was interesting. Thank you all for sharing your knowledge about Sedona. So I just wanted to state that this is a non-CME event sponsored by Pfizer, and I am, of course, it's in accordance with FDA guidelines and Pfizer prescription information. However, I am supposed to keep it within on label, and any other questions that do not belong to this topic will have to be addressed at a later time. So with that being said, we're going to talk about palbociclib or Ibrance. As you know, it has been approved in the treatment of hormone receptor positive, HER2 negative metastatic breast cancer in combination with aromatase inhibitor in the first line setting and in combination with fulvestrant or oral SERD after progression or endocrine resistant tumors. So when we talk about the indication, I have to have a fair balance here to talk about some warnings and precautions. And as you are all very familiar with it, neutropenia happens to be one of the most common warning and precaution with use of Ibrance, and we see that in almost 80% of all people who experience all grades neutropenia, and 50% or more grade 3 neutropenia. But it's good to note that febrile neutropenia happens in just about less than 2% of these patients. There was one death reported in PALOMA-3 trial. Nevertheless, it has heightened awareness and guidelines established how to monitor these patients with CBC, how frequently and when to dose reduce and dose interrupt. Another warning and precaution that's come about is interstitial lung disease. I know that we've all become familiar with monitoring for this particular AE. However, this AE, interstitial lung disease, is not unique to palbociclib or Ibrance alone. It is to all three CDK4/6 inhibitors, and it occurred as a post-marketing setting that it was noted in real-world practice, and so it came about as a warning. It's also good to note that 1% of patients experience ILD of all grades, less than 1% grade 3 or more. But we do monitor for any symptoms suggestive of ILD and have to discontinue or even interrupt treatment if necessary. Lastly, it is common knowledge that this is teratogenic. It can cause fetal harm, so we tell our patients to not become pregnant when on Ibrance. And also, for male patients, it may cause harm, so they may want to cryopreserve their sperm, and if they have female partners, advise them to not become pregnant, not just for a few weeks, but for 3 months after the last dose. And they should not be breastfeeding while on Ibrance as well. So with that, we're going to talk about 2 clinical trials, and the first of which is PALOMA-2. This is a Pfizer-sponsored randomized clinical trial. We're going to talk about the pre-specified analyses of PALOMA-2 trial, which led to FDA approval of use of palbociclib or Ibrance in this setting of hormone receptor positive, HER2 negative metastatic breast cancer in the first-line treatment. And then we'll also give an update on non-pre-specified analyses of PALOMA-2 trial. And then the second trial is Farsifal, which most of us may not be all that familiar with, but this is an investigator-initiated randomized control phase 2 trial, and this was basically looking at which is a better endocrine partner to be paired with Ibrance. So we'll talk about both Farsifal initial and pre-specified analyses, as well as Farsifal long, which is extended follow-up analyses on these patients. So we'll start with a case to put things in perspective. So I'm going to talk about Donna, and she's postmenopausal, who presents with symptoms of back pain and some chest wall symptoms. So her story goes back to when she was 62 years of age. She presents with a palpable breast mass confirming diagnosis of invasive breast cancer that is estrogen receptor positive and HER2 negative. She receives standard of care treatment with neoadjuvant chemotherapy followed by surgery, radiation, and then endocrine therapy. As she was postmenopausal, she got aromatase inhibitor for 2 years, and she chose to discontinue therapy. So now, 2 years later, or a few years later, she's now 69 years of age, and when she presents with symptoms of chest wall discomfort and back pain, and workup led to diagnosis of metastatic breast cancer with bone-only involvement confirmed on a biopsy and very similar breast panel markers, she has been disease-free for at least more than 24 months. So I just wanted to recap what is endocrine sensitive and what is endocrine resistant. So endocrine sensitive tumors are those that get diagnosed as stage 4 breast cancer, or if they have been disease-free more than 12 months of having received an aromatase inhibitor or adjuvant endocrine therapy. On the other hand, endocrine-resistant tumors are those that have developed metastatic breast cancer while receiving adjuvant aromatase inhibitor or within 12 months of being on adjuvant endocrine therapy. So with that being said, let's first review PALOMA-2 trial, both pre-specified and non-pre-specified analyses. So I know that many of you, all of us, are extremely familiar with this landmark study, which led to FDA approval of use of palbociclib in this setting. So this is a phase 3 randomized controlled trial where postmenopausal women who got diagnosed with metastatic hormone receptor positive HER2 negative breast cancers and have not received any prior therapy were randomized in a 2-to-1 fashion to receiving palbociclib or Ibrance at the dose of 125 milligrams orally daily, 3 weeks on, 1 week off, in combination with an aromatase inhibitor, and here letrozole was used, and the other arm had placebo with letrozole. So progression-free survival was the primary endpoint by investigator assessed, and then a few secondary endpoints like objective response rates, overall survival, safety, and tolerability. They stratified these patients based on whether they had lung and liver mets or not, and also whether they were endocrine sensitive or not, and the type of prior therapy that they received in the adjuvant setting. Now, when you look at the demographics in this study and compare it to our hypothetical patient, median age of enrollment in this study was 62 years, and our patient was more than 65 years. She was 69, right? So 40% of patients in this trial were above 65 years. And then our patient had bone-only metastases, which was noted in about a quarter of patients in PALOMA trial. And she was endocrine sensitive in the sense she had more than 2 years of being off of aromatase inhibitor. About 40% in the study were endocrine sensitive. And then, of course, every patient enrolled in a study have to have good performance status with ECOG 0 or 1, and she did have prior endocrine therapy, just as about 60% or so in this study. So here are the results of PALOMA-2 in the pre-specified analyses. As you could see in this Kaplan-Meier graph, the curves separate, and the one in green is representing combination of palbociclib and letrozole. And you see that it clearly favors the combination with a median progression-free survival of 24.8 months in the pre-specified analyses as compared to just 14.5 months with use of letrozole alone, which was statistically significant with a hazard ratio of 0.58, indicating that there is at least a 42% improvement in the progression of their disease or death. So this was pretty significant. And now we want to know what are the few secondary endpoints and did they meet them. So the objective response rate seemed better with combination of palbociclib with AI. As you see here, 55% had an objective response rate as compared to 44% with use of AI alone. Another secondary endpoint, which was overall survival, it was not met as it was not statistically significant after they reviewed following several events, close to 500 events. So the median overall survival was about close to 54 months with palbociclib arm as compared to 50 months with AI alone. So with that being said, a few of the adverse reactions that you see in more than 10%, although it is a busy column here, the one in green is representing palbociclib combination, and the gray is AI alone. And the first one is all grades, and subsequently you see grade 3 and 4. It's even hard for me to see these numbers, but it's important to note that neutropenia is the most common adverse reaction that happens in 80% of all grades when you use palbociclib, and more than 50% grade 3 and 4, but all of the other adverse reactions happens to be a very small number with grade 3 and 4 toxicity. And as I see in my practice, and I'm sure all of you see in your practice as well, a few of these patients experience fatigue or other GI toxicities, like maybe nausea, stomatitis, and perhaps even headache, skin rashes, hair thinning. These are some of the other things. Of course, with neutropenia, you have a concern with infections. Almost, as you see here, 60% of all grades had infections, but grade 3 and 4 were in single digits. So that's not really of a major concern, but it heightens our awareness to monitor for these. And there were a few non-hematological lab abnormalities like elevation of transaminases in a very small number of patients. And as a result of any of these toxicities, about 10% of patients enrolled in the study had to discontinue Ibrance permanently, as compared to 6% that discontinued AI as well. And if you may imagine neutropenia to be perhaps the commonest reason for discontinuation, that was not the case. It's only 1% or so that discontinued due to neutropenia. It was for various other reasons. And however, a fairly large number of patients, 36% or so, required dose reduction of Ibrance. So when we look at non-pre-specified analyses, this is important and meaningful because we want to know beyond the clinical trial pre-specified data, does it really work? And you see the graphs remain separated. And in the non-pre-specified analyses, palbociclib combination continues to emerge as a better option of treatment of almost 28 months as a median PFS here, as compared to 14 and a half months if you use AI alone. I think this is a great slide to tell our patients by using this combination how we are able to postpone use of chemotherapy further and further, and with the use of an oral agent preserving their quality of life and so on. Now, in the non-pre-specified, you want to see if they fared well in various subgroups. And that's what we see in this forest plot analyses here. And most of these subgroups, it is to the left of one, indicating that it's favoring use of palbociclib or Ibrance AI combination, regardless of whether they were over or below 65 years of age, regardless of whether they were endocrine sensitive or not, regardless of whether they had visceral disease or bone-only metastases. But it's also important to note that these subgroup analyses is just giving us an idea as to how they perform in each of these subgroups, but it's not meant for statistical analyses as the numbers are small and was not designed to do so. And you look at individual subgroup analyses as to how they did with their progression-free survival. For instance, if they got diagnosed as stage 4 disease, combination of palbociclib and Ibrance, almost 28 months progression-free survival. When you look at endocrine-sensitive patients, almost more than 30 months progression-free survival when compared to AI alone. And in the pre-specified final overall survival analyses, once again, you see what the various subgroups have performed in this forest plot, but again, take it with a grain of salt as it is not meant for statistical inferences. Again, it continued to show improvement in the overall survival, but probably not so much so with de novo or stage 4 disease. As you see the numbers here, the combination arm perhaps had less overall survival as compared to letrozole alone. However, if they were endocrine sensitive, the overall survival outdid combination arm as compared to AI. But you know that it didn't meet the overall survival analyses. Now, more of the adverse events that was reported based on the updated non-pre-specified analyses and the final overall survival analyses. It just goes to show that these were similar to what we saw in the initial analyses with neutropenia and a few other lab abnormalities, what we saw, and other abnormalities, mainly GI, and there wasn't any new safety signals that was observed. When they also looked at pooled analyses data with both Paloma 3 and 2 data, once again, there wasn't any new safety signals that was observed. There were a few patients that experienced, in addition to neutropenia, thrombocytopenia, and anemia, as well as I mentioned earlier, elevated transaminases, and so on. Again, we're also familiar with this information. 125 milligrams is the strength of Ibrance that we use for 3 weeks on, 1 week off, and combined with either if you're using aromatase inhibitor or a SERT, these are the standard doses as we have used in our clinic. Many a times our patients, when I ask them, say, have you taken your dose today? They said, no, I missed my dose because I didn't get my breakfast. So that process is eliminated with the use of Ibrance in the form of tablets. It certainly can be taken with or without food, so it's really important to stress to our patients they can't take their medication even if they haven't had breakfast. And with use of capsules, perhaps that was not the case. And sometimes patients, if they did throw up, they don't need to take another dose on the same day. And I do use LHRH agonists for younger women as well as for men who use Ibrance with an AI, and that's what's recommended as well. Okay, a word about CYP3CA inhibitors and inducers. You know, a lot of our patients take so many concomitant medications, so that's why it's really important to see what they're on, whether they are going to exaggerate the side effects of Ibrance or reduce the efficacy. So we do know that using CYP3CA inhibitors can increase the toxicity of Ibrance, and sometimes we may not know which are CYP3C inhibitors. No doubt our pharmacists are of great help, but nevertheless some outliers can be use of certain antibiotics, clarithromycin and things like that, grapefruit juice, and also ketoconazole. These can be some of CYP3CA inhibitors. And you have to be careful and perhaps even reduce the dose of palbociclib if need be. And CYP3CA inducers may reduce the efficacy of Ibrance, and to know which are those, there are some anti-seizure medications, anticonvulsants, rifampin, those could be some of CYP3C inducers. So they may not be as effective, so you may want to make sure that when they get off of the medication, you have increased the dose of palbociclib to the regular strength. And if patients have some renal and hepatic impairment, we want to know, can we use Ibrance? Yes, most certainly you can do so, and you can use it if they have Child-Pugh A or B, hepatic injury, but probably reduce the dose if they have Child-Pugh C. And in terms of renal impairment, it hasn't been studied if they're on dialysis, but certainly can be used up to creatinine clearance of 30 and above. And so our patient, going back to hypothetical case Donna, who had presented with metastatic breast cancer, bone-only metastases, and endocrine sensitive, she was placed on Ibrance and AI. And as you see, she developed neutropenia after 3 months of treatment, and that required dose interruption and was reduced to 100 milligrams of Ibrance. And she had a few other side effects like fatigue and nausea. And 2 years later, she remains on therapy, and you see that she has fewer metastases, doing well with maintaining her quality of life. So that's putting it into perspective. So it's also common knowledge that it takes approximately about 2 weeks for neutropenia to happen, and about a week or so for neutropenia to resolve. So that's why we monitor blood work when we start our patients on Ibrance, particularly in the first 2 months, doing it every 2 weeks, thereafter once a month for a couple of months, and thereafter based on individual patients' findings and using your discretion as well. As I mentioned earlier, it's now in the tablet form instead of capsule form, and then you do dose reduce for AEs from 125 to 100 as first reduction, and then 75 milligrams as second dose reduction. And there are clear parameters and guidelines how to manage AEs with dose interruptions and reduction. If you have to hold treatment for hematological toxicity like neutropenia, if they have a neutrophil count of anywhere between 1,000 to 1,500. You don't have to, that's grade 2, you don't have a grade 3, grade 2. You don't have to hold Ibrance, you can continue. However, if they develop grade 3, that is ANC of 500 to 1,000, you probably want to hold it, and if they recover quickly, resume at the same dose. If it happens again, dose reduce at that time. And if it's grade 4 less than 500, you may want to hold and dose reduce. There are similar parameters for non-hematological toxicities to hold and dose reduce based on the severity or grading. And then always keep in mind to monitor for interstitial lung disease, despite the incidence being less than 1%, that's serious ILD or pneumonitis. So with that, I'm going to move on to the second trial. This is an investigator-initiated randomized controlled trial. It's an open-label trial. It's a phase 2 trial called the Farsifal. We're going to look at both pre-specified analyses and non-pre-specified analyses. That's a Farsifal long. So the premise of this trial is the fact we know that fulvestrant or a SERD has shown to have superiority over aromatase inhibitor without combination of CDK4/6 inhibitor. However, here they wanted to prove which would be a better endocrine partner to be paired with a CDK4/6 inhibitor. Would it be an AI or could it be a SERD like fulvestrant? So this was a study done in 47 centers, international studies, 7 countries, and it's an open-label trial, as I mentioned earlier. So in this phase 2 trial, men and women and premenopausal women as well who were diagnosed with metastatic or de novo breast cancer that was hormone receptor positive and HER2 negative and endocrine sensitive, who have not received any treatment in the first-line setting, were randomized 1-to-1 to receiving palbociclib with either letrozole or fulvestrant. So the comparator arm here was fulvestrant with palbociclib. And the primary endpoint was investigator-assessed progression-free survival and a few secondary endpoints like overall survival and safety. They stratified these patients based on whether they presented as stage 4 or metastatic disease and whether they had lung and liver mets or otherwise. As I mentioned earlier, this was an open-label study. It's also important to note that a select number of patients in the comparator arm, which is fulvestrant with Ibrance or palbociclib, had not received any prior endocrine therapy. So that's something to note. And as always, there are few study limitations that comes with an open-label study and investigator-assessed trial. And here's a few of them that's listed. You know, we have to be cautious when you're interpreting design and results from an open-label study. And also, when it is an investigator-assessed primary endpoint and few secondary endpoints, we know that this is not confirmed by independent review, even though they may use RECIST criteria. It certainly comes with certain biases, and the disease progression is based on what the investigator thinks it is. And lastly, overall survival analyses was not powered to show statistical significance in the study. They did not capture safety data at all in the study, and the overall survival was immature at the time of analyses, and of course, it lacked diversity as well. So who were enrolled in the study? I know it's a busy slide with the demographics. The median age in this study, women were 62 years of age. They obviously, most of them were white, very small number of different ethnicity enrolled in the study. Good performance status, more than 90% of these patients were postmenopausal, and they did have visceral disease in about half of these patients, and you could see that majority of them received adjuvant treatment in the early stage setting, and a few of them got neoadjuvant therapy. Most of them got endocrine therapy, but they were tamoxifen followed by AI or tamoxifen alone or AI alone. And about 40% of these patients presented as stage 4 disease. Now, when you look at the results of Parsifal study, it's very clear we don't need rocket science to interpret these results shown on Kaplan-Meier graph, that the two graphs overlap each other. So although fulvestrant is shown to be an excellent endocrine agent, but when combined with palbociclib, it did not show any superiority over AI and palbociclib. So the median PFS after 32 months of follow-up was 32.8 months when you used Ibrance with an AI, and there was no difference when you used fulvestrant with an AI. So this is the first of its kind to compare the two different endocrine agents to have been paired with a CDK4/6 inhibitor and did not show any difference in the PFS, which was the primary endpoint. When you look at overall survival, which is a secondary endpoint, once again, the same thing. The graphs overlap here, showing that there was no difference whether you used either AI or fulvestrant combined with palbociclib. Note that overall survival was immature at the time of data cutoff, and this was in January of 2020. You would see a little additional data in the Parsifal long, but then more to come as they are about to present additional follow-up data on this study. Once again, I do want to remind you that in the comparator arm in Parsifal study, a select number of patients had not received prior endocrine therapy. And again, a reminder that in Paloma-2 trial, it did not meet the secondary endpoint, which was overall survival. The AEs in Parsifal study was no different from what we saw in the other Paloma trials. They were almost identical, neutropenia being the outlier of all grades more than 85% and more than 50% grade 3, and remainder of AEs were very similar to what we saw, both hematological as well as non-hematological AEs that we saw. Now, ending with Parsifal long study, which was an extended follow-up analysis of the Parsifal study, and this was additional follow-up of the same data. 80% of patients who were in the Parsifal study qualified for the Parsifal long study, and they matched all of their demographics and disease characteristics for evaluation. However, the endpoint here, the primary endpoint, they looked at extended overall survival, and the secondary endpoint, they looked at extended progression-free survival. They kind of flip-flopped here. But once again, I want to bring it to your attention that there are study limitations even with Parsifal long study. So this data is not in a journal that we are familiar with. It's not peer-reviewed. It was presented as an rapid abstract at San Antonio 2023 conference, and so there are some limitations. And in Parsifal long study, it was extended data up until May 2023, but they're looking into additional follow-up after data cutoff in January of 2024. And once again, some patients in the comparator arm did not receive prior endocrine therapy. But the results of Parsifal long study was not anything different. We see exactly the same what we saw in the Parsifal study. Both of these arms did exactly the same results, gave the same results. The graphs overlap each other. The endocrine partner was not able to show superiority with one over the other when combined with Ibrance or palbociclib on an extended study in the overall survival. And likewise with progression-free survival as well. The median progression-free survival after extended follow-up is almost 35 months when you used Ibrance, and similar with the other arm as well. So with that, I want to end saying that Ibrance has been in use in all of our clinics, in all of our practices for 10 years plus since it was first approved in February of 2015 in the treatment of metastatic hormone receptor positive, HER2 negative breast cancer, either as a first line or second line. And thank you so much for listening, and I certainly would encourage any comments, questions, anything you might want to share. Thank you.
right, at this time, I'm going to invite Sammy back up. I encourage everybody to participate in her presentation, and we'll get some movement going.
Always. I mean, the official movement is later, but hello. Hi. Oh gosh, we got to work on this. Oh, I have 15 seconds left over of the last presentation. Why don't we all just stand up for a second? I won't make you jump up and down yet, but let's just stretch out our shoulders, reach overhead. Oh yeah, pull those shoulder blades together, elbows down. Let's go forward and back, couple side to side. Yes, I know. All right, now you can sit down. See, that wasn't so terrible. All right, so I am a stand-in. We are not doing yoga. I do yoga once in a while on my own. And I was telling a couple of our colleagues here that once I got kicked out of yoga, not kicked out, asked to not come back because I constantly fell asleep during Shavasana. You ever know what that is? Right, at the end. But I'm gonna change this, so I am gonna take the opportunity, since Sandi is unfortunately not able to be here, and actually focus on topics that have already been teed up for me today, but I really love talking about, which is my favorite parts of lifestyle being nutrition and exercise. So we're gonna talk about some practical pieces, and then we'll have some fun doing implementation. So why does lifestyle matter? This is, as mentioned before, we know that lifestyle matters in risk reducing cancer as well as improving outcomes. What does this mean? There's a lot of versions of this, but the main thing that we need to really recommend, obviously excess weight. And I'm gonna kind of debate you on, is this BMI? What's the other one? Body weight. Oh, who said it? Yeah, body roundness. Yeah, that one, whew. But I mean, yes, I get it, but who wants to be body round, right? Thank you, but no. I didn't like BMI, but yes. And then we would talk about low quality diet and physical inactivity. I think often we think about all the things we need to do versus the things that we should avoid. And I think that's a very simple perspective, especially when we're translating this into working with busy colleagues, we have busy families, we're taking care of patients and individuals that have so many barriers to this particular perfect diet. And I want us to think very simplistically about this, and I love to follow a lot of the American Institute of Cancer Research information. They have a lot of good tools that really, as we've heard from several of our speakers, bring this message home in a way that's very accessible. And I always remind us, we need to follow solid science where we can and be thoughtful when we're also learning for ourselves as well. So what do I get to talk about? This is one of my favorite topics. I started my career 23 years ago in May. As a little cancer exercise trainer, I was living in Kansas City. I actually was able to start with a clinical trial and an academic practice because they needed an exercise person in cancer. 23 years ago, there was not very many of us. So find the only chick in Kansas City, it was me. And we did this study. It was an energy balance study looking at postmenopausal breast cancer. And it was a diet and exercise study. And they said, Sammy, would you write the exercise protocol? And I said, great. And I had the opportunity to work with this study where we put our patients on the DEXA scanner, not for bone density, for body composition and skeletal mass and fat mass. That study was published in 2006. And I always thought, for me, it was practice changing to understand muscle versus fat. It wasn't just weight. So my life's work is based on this term, which I used to start all my presentations with. What is sarcopenia? We all know what sarcopenia is, right? So are we overly fat or under muscled? Both. What does the number really mean? And I want to argue that I think the trick and the power of lifestyle medicine is that we all want to stay on the left, not the right. These people have the same BMI. We know that quality of life is different, our energy is different, our function is different. We might be a little bit more nervous about the Jeep tour today or what Sammy's gonna do, but I really want us to think about how not only do we live long, but we live well. So sarcopenia, I call it as a condition of being human. Why is sarcopenia such a big deal? Why is it so prevalent? What do you all think? Who knows why sarcopenia is so prevalent? Oh, come on. No, that's mean. That's a good one, but okay, how many of you have this thing called a computer and an EMR on your computer, and then I have a phone and a tablet. And how many of us are like, I shouldn't necessarily walk around and text. I do have people yell at me for doing that. But right, we sit. We sit. The thing that we need to really understand is that the average number of hours that we as adults in the United States sit per day, that was reported in 2023, was 9.4 hours. So we heard this earlier. You can't out-exercise that. So sarcopenia is a condition of being human. It is a condition that we have to constantly work against because we have to be up, active, building muscle, having enough nutrition in our diet. So in the United States, well, actually, let me say this. There's two things that I'm fascinated with. One, of course, is lifespan. I've worked in cancer for 23 years. How long are you gonna live? The last decade of my life, I've shifted to this really exciting term, I think, called health span. How well do you live? So yes, I want people to live long, but I want them to live well. When I worked in academic medicine and I was in a clinical practice, and I would go see patients in the treatment room or in the inpatient side of the hospital, I did a lot of work in BMT, and they'd say to me, I just care about getting on this cruise. And I'd be like, awesome, how do we get you there? To me, that was health span. Yes, lifespan, but health span. So we know that the health span gap globally is 10 years. Lifespan to health span, how many years you live versus how many years you live well is a decade. In the United States, we are 12.4. We are almost 30% higher. I think a lot of it has a lot to do with our inactivity. So again, I would love you all to exercise regularly, but mostly I just want you to sit less. Fair? Does that sound nicer? It's not because you're lazy. There are some people. So let me ask you this, in lifestyle, I brought this slide. I often use this when I talk to patients, but I think it makes sense. What is your lifestyle landscape that you see the most? So how many of you have heard of this whole don't lose the forest for the trees bit, right? And sometimes I wonder, what does that mean? Forest, trees, what am I focusing on? So I wanna ask you, what does your lifestyle landscape look like for your health span? Are you looking for a path amidst the forest? Are you chopping down a few trees, a few things? I'm really focusing on maybe my nutrition, my stress, my sleep, whatever. Or are you distracted by the chimps? Without a doubt. Because how many of us are like, okay, I have 5 seconds. It seems exciting to get on social media, see what's going on, and then there's this person that shows this amazing meal thing. I'm gonna do that every day. Oh my God, that workout, that is gonna be the best thing for my booty and my abs and my arms or what, right? I'm gonna do that. We all get this way. This is also the thing that I remind us as humans. We are all being monetized. And this is part of the monetization. So I just want you to kind of think about that. But let's get practical. I love to talk about exercise. I love to talk about lifestyle. I came from 23 years of exercise. I've shifted into lifestyle medicine because I realize you can't just talk about one without everything else, but my passion and where I think so much of the really quality research continues to be in exercise. So we know that in overall, there was a prospective study, this was actually published now about 4 years ago, looking at adults globally. This wasn't cancer, but just looking at adults that met the physical activity, which are actually exercise, by the way, recommendations. How many of you know what the physical activity / exercise recommendations are? 150 minutes of moderate physical activity per week, right? Including 2 days a week of strengthening, which didn't become standard care in cancer until 2019 to include strengthening. But we knew that for adults that meet those guidelines, which is also self-reported. Okay, I'm gonna pause. How many of you work out in a gym setting? Does anybody wonder how much people are working out versus on their phone? Like, I have got to rest between a set. I need to check my, right? Yes. So I always say, is patient, like individual reported, I want to ponder, right? Granted, we have science that is different, but I think this still is also kind of curious for me. Is this really 150 minutes or maybe it's half? So it tells me that exercise is powerful. We know that we can improve all-cause mortality, 41%, cancer mortality by 46%. Recently, just published the end of last year, we looked at the combination of strength and cardiorespiratory, cardiovascular fitness to improve outcomes in cancer. The data was actually similar, 46%. This study, which was, again, a retrospective study, included metastatic. I work a lot in metastatic cancer. I was part of the bone metastasis recommendations that we published in 2022, basically saying that it is beneficial and that sedentary behavior is worse for someone with bone metastasis. Certainly, we want them to have recommendations of what to do, but it showed that it was still an important tool in the tool belt for the outcomes of our individuals. So I love this picture of my healthy muscle versus fat infiltration. This happens when we sit too much, our muscle fibers atrophy, and a lot of our dietary changes. Yes, there's some discussion of, is stress cause this, poor sleep cause this inflammatory response. I say overall, let's think simple and look at the things that we can control. I call muscle the organ of longevity. How many of you would literally trade your quality of life over your quantity if it meant you can do the things that you love? There is great research in this, and they call it time trade-off research, where we asked individuals with specific chronic conditions, what's more important to you? Living 10 years at a lower quality of life, or living 3 years being able to do the things that are important to you? And this isn't climbing Mount Kilimanjaro. I mean, certainly it could be, but again, it's quality over quantity. Same thing, our patients care about it, we care about it, but often we're too busy caring for them that we forget to care for ourselves. We've talked a little bit about that. But I always want to remind you, it's the organ of longevity. And I'll give you a quick little way to test this tomorrow, but we won't do that today. It's kind of fun, but I'll just share it. I won't make anyone demonstrate it. So there's so many benefits of exercise. I pulled this from a patient slide, so it's a little bit more fun. But these are some of the main benefits of exercise. It's of just generally exercise. Let me ask you the question, does the type of exercise matter in these specific criteria? What do y'all think? I love this. Everyone's like, yes, wait, hold on, she's pausing. We're so human sometimes. It does matter. I actually want to go, I reordered my slides. I want to actually say it does matter. There is great data in all the types of fitness that we heard about, cardiorespiratory, strength, flexibility, absolutely really important. But when we think about really longevity, the reason that the type matters is that we have to prioritize. Because I don't know about you, but still in my career, no one's ever paid me to be like some fitness influencer, right? I want to be, to like be the full-time job of my fitness. I would do it all then. Probably have some fun along the way. But I always want to remind people that regular exercise, prioritizing strength, making sure you don't miss it, you can do this in a creative fashion on your Pelotons or with Pilates or with yoga. But we just need to remember that we need to make our muscles work. This is key. I love functional exercise because functional exercise, which is multi-joint movements that help you with day-to-day life, more bang for your buck. So as much as we like to go in the mirror and do those little arm curls, can you maybe add something to that, right? Maybe turn it into something where you're doing a deadlift. Maybe you're adding a shoulder press. Why? Because more joints mean more muscle recruitment. It's a little bit more efficient. We have to challenge our muscles. This, for us as humans, challenges our mind. When we do hard things, in my belief in the fitness and exercise setting, we build up our ability to tolerate more challenging things in day-to-day life. And I think that's important. We also need to make time for recovery. So do not forget that we need to take time off. You can't go after it every single day. So I'm gonna go back. My prescription for strength is for everybody. I do this for individuals with cancer, but I do this for my colleagues. What's really fun about talks like this when I talk about patient work is someone comes up to me and they're like, can I ask you a question? And you know it's invariably about themselves, but I love that because I feel that this is such a critical part of what we do. The more that we understand, the more we can translate to those around us. So I tell people, I like you to do strengthening 3 times a week. Does this mean an hour in the gym? Only if you want to. But again, one of the things about muscle and skeletal muscle is we need to break a muscle tissue down or muscle fiber down so that our body will rebuild it. And then we break it down again. That's how those fibers get stronger. So this is sort of my very simplistic side with people as I say, listen, I'd rather you do one thing 3 times a week than just do it once and never do it again that week. So think about that in your general prescription. I like the intensity to be a little bit higher. This is from a muscle perspective, so you need to make sure that you feel the burn. There is a reason that we push people to do that. Right type of exercise, et cetera, but important. All right, moving on. Nutrition, the #1 question people ask me. I used to be sad when I worked in the clinical setting and I'd walk in and I'd say, hi, I'm Sammy. I stopped introducing myself as the exercise person because people would say, is the dietitian coming? And I'm like, but hold on, right? I think nutrition is so critical. And so I love that this is sort of where my work has taken me, but they really do pair together, so important. So from a nutrition perspective, where we have the data, the science for all of us, is these are my top 4. Make sure that you consider less processed or minimally processed foods. We need to make sure we still have enough protein to meet the needs of our skeletal muscle, our immune system. We need to have predominantly plants. That's where a lot of our, not a lot of, all of our fiber comes from, a lot of our nutrients, vitamins and minerals come from, and we need somewhat of a calorie balance. I'm not saying that this is about calories in and calories out. It's not that simple, but we need to have some balance as far as what we consume. From a nutrition perspective, I like to tell people that when we're looking for whole foods, sometimes snacks are the easiest places where we can find whole foods. An apple, some nuts, something that's really like a hard-boiled egg. Whole foods often are really useful in snacks, but we don't think about that. We think, ooh, tasty snacks. Why? Because we are a product of the food industry in that way. When we think about dietary patterns, I love that a Mediterranean diet pattern can be a really great tool. And then honestly, in my world, when I'm trying to get so many people to get enough protein, I often recommend that they add supplementation. I'm notoriously known to, when I travel with 3 things, always. I always bring protein powder. This is going through the airport, by the way, so, and yes, sometimes I get stopped. I always bring instant coffee, instant espresso, because you never know what you're gonna get, right? And I always have tuna pouches or salmon pouches, because I find it's easier to find vegetables than it is to find protein. That's me. People find that fascinating, but that's kind of my brand. And so I tell people, like, if you have to supplement because it's convenient, buy high quality if you can, but at the end of the day, do what matters for you. Also, when I'm working with people, this can be very economical. Buying whole foods, especially in some of these quantities, can be really difficult for individuals that maybe don't have that kind of income. All right, lastly, I think food should be fun. How many of you think food should be fun? Who's seen this app? What? Oh, yes. I love this audience. Okay. Here's the question. So on the bottom left, I live in downtown Denver right now, and we live close to a Whole Foods. I do not always shop there, right? But I went in there looking for peanut butter, because I make these homemade peanut butter cup things for my spouse, who does not like to share them with me, so I make him his own, and then I sort of make my side version. But I was looking for peanut butter. So here, these were sitting exactly side by side on the shelf. So does anyone see the differences of these? What do we see? Okay. What? Spread, right? Peanut butter spread is basically Skippy, Jif, palm oil, ooh, right? But what happens when you're in a hurry? Whoever shops in a hurry? Most of us. The rest of you are like, I don't shop, I just order it and it delivers. No judgment. However, when you're in a hurry or you're teaching someone, the number one thing about food that I believe is the most important is processed versus unprocessed or less processed, right? This app is a free app. It's French-based. You can literally download it for free. There is a subscription. It's $15 a year if you want it to give you suggestions, but it works great and free. It is the number one tool that I've given colleagues and a lot of my kind of patient-facing work to scan the food label and understand what it is. It scores it, as you can see, on 0 to 100, and then it tells you why. So you can dig as deep as you want, or you can just go for the number. So here's what I find fascinating. Protein bars. Basically, cereal snack bars with protein. There's some value of a couple, but people notoriously are like, Sammy, what's the best protein bar? And I'm like, well, there really is only like now one that I believe is okay. But again, it's still got some good fake sweeteners in it, even though it has high protein. But this is a really good tool and an app for those of you that are wanting to make your life easier. You're wanting to find some ways to quickly choose nutrition choices that are healthier. Okay, so by the way, I do not get endorsed by this company. Maybe I should go work for them because I love it. But it is really a really cool tool to understand, again, some of the pieces of your nutrition. Okay? All right, with that said, I have just a few minutes left. If anyone has questions, I'll take a question. If not, I'm gonna pass it over because we'll keep moving because we have a Jeep tour. Anyone? Okay, I'll be back up before lunch then. I'll see you all then. Thank you.
Thank you, Sammy. I don't know about everybody, but I can't wait to download that app. I would like to introduce our next speaker, Dr. Shahin. He's going to present our next session. If everybody could please welcome him.
Good morning, everyone. Thank you for taking time out of your day instead of hiking the trails around here, hanging out with me. My hope is over the next 20 minutes, I'll just bring you up to date with where we are with the use of PARP inhibitors as well as immunotherapy in two of the most challenging diseases that I face as a gynecologic oncologist in the clinic, with uterine and ovarian cancer. In ovarian cancer, we really have come to understand that just the histology alone is not sufficient to actually treat the patient, and the molecular markers really are the driven way to make decisions about treatments. So our high-grade serous carcinomas and low-grade serous carcinomas are completely different diseases. When these patients recur, our treatment approaches are completely separate. In our low-grade tumors, we actually see more similarity in treatment to that of breast cancer. Certainly in our mucinous clear cell and endometrioid diseases, also we encounter mutations that really make a difference, especially when we're trying to select patients and target them toward specific clinical trials. So I just put it out there that really the molecular changes that are driving these histologies are different. Now, one of the most significant things that's happened is, and we need to understand that right away, when a patient is diagnosed with newly advanced ovary cancer, is to understand them, are they homologous recombinant deficient or are they HR proficient? Because that will likely lead to some additional recommendations post completion of the initial therapy. The algorithm for management of patients with ovarian cancer has become somewhat complicated. 20 years ago, I didn't think about it much, and I pretty much operated on everybody. Whereas today, we do biopsies, laparoscopy, a lot of imaging, looking at the molecular markers, decide whether is cytoreduction appropriate here or not. And then we have to come up with pathways to decide what do we do about maintenance. So I put a bunch of boxes in front of the patients, honestly, to decide, at every step of the way, based on the information that we acquire, how best to manage them after that. So the goal is still at some point for the patients to get a complete cytoreduction. The question is timing, and when cytoreductive surgery is not feasible, oftentimes we start with neoadjuvant chemotherapy for 3 or 4 cycles before we decide what the next step should be. I've lived through about 25 years of what I would say significant progress in ovarian cancer, and I do have to put a plug for, we're in Arizona. John McCain was a huge proponent of the line item for Department of Defense funding for ovarian cancer. And the progress that's happened in the last 25 years would have not been feasible with this $40 million that's been dedicated and was up to $45 million last year. This year, it just got cut by 57%. So sometimes the fruits of the labor shows up 10, 15, 20 years down the road. And I do worry about the future given what we're living through today. So several studies really have shifted the paradigm in how we treat ovarian cancer. And I won't go into a lot of details, but I will tell you PARP inhibitors really have changed the management of ovarian cancer. And what I do like to talk about is that the hazard ratio of benefit that we see in BRCA mutated patients, as well as those who are HR deficient, is consistent across multiple trials. this, as a practitioner, gives me confidence that this is not just a drug effect, it's really a class effect. And that's why I'm a big believer in that. One of the hardest decisions we have to decide, SOLO-1 was a trial that really established olaparib as their primary maintenance agent, and it's 2 years of maintenance therapy. And I don't know about you guys, it's not hard to put them on, it's actually hard to take them off the maintenance therapy. Patients look at that as the key to survival. And I think we, as healthcare providers, we need to, the next step is to figure out, is 2 years really what they need? Because I just heard from my colleague who discussed the Olympia trial, how 1 year of treatment was sufficient in breast cancer. So why is ovarian cancer different? But one of the harder things to do is, should we add bevacizumab to BRCA mutated patients or not? And I did a sort of something that's sacrosanct, which is put the data from SOLO-1 as well as the data from PAOLA-1 trial on the same graph. And it does show that in our high-risk patients, the olaparib plus bevacizumab may actually be slightly more beneficial. Obviously, I'm comparing 2 trials at the same time. Now, one of the things that I hear a lot, especially from my colleagues in GYN oncology, is that this patient is low risk. I don't need to really give him bevacizumab. So we took the results from the PAOLA-1 trial, which was an IIT, mostly done in Europe. And we looked at our high-risk patients. So these are the patients who have ascites, pleural effusion, a lot of upper abdominal disease, and compared them to what the study was lower-risk patients. And you can see that the magnitude of benefit actually is much larger for our lower-risk patients, with a hazard ratio of 0.15. And I understand that this is an ad hoc analysis, but I hope that this kind of data gives you the necessary armamentarium when you go on Monday to the clinic to actually make decisions to really push for the best treatment for your patients, including the lower risk HRD positive patients. And for those of us who treat ovarian cancer, I never look at anybody as low risk, honestly. Everybody has the potential to come back. One of the more important measures that really has impressed me is that following 5 or 6 years data now in that PAOLA-1 study in our HRD positive patients, we're actually seeing overall survival benefit. And we haven't really had this type of strong data in ovarian cancer. So I'm very encouraged by that. And again, looking at both higher and lower risk patients, we see an overall survival benefit in both of those populations. One of the trials that failed to show overall survival benefit was the PRIMA trial. This is the study that looked at niraparib in our patients, and the population here probably and perhaps was different. But there was no overall survival benefit, and some people have looked at this as, what's going on? Is this a bad drug? I would say that the clinical trial was different. Certainly the combination of bevacizumab in the other trial before randomization versus monotherapy may have some effect in that. There was a lot of cross trial, meaning that after the patients progressed, they actually got a PARP inhibitor afterward. And I will tell you that the patients who went on this trial had to have measurable disease, so it wasn't a very low-risk population. So perhaps those factors might have led to the lack of overall survival. One of the things that I emphasize to my colleagues is also that when we do interval surgery, that our pathologists actually comment about chemotherapy response score. So if a patient has a very good response to chemotherapy, that is almost a surrogate to a HRD, and makes me really want to put those patients on PARP inhibitor because they would benefit from it. The safety profile of the PARP inhibitors have been really looked at in our first-line trials, and I would say to you that in olaparib, we see essentially somewhere in the neighborhood of 50-60% dose interruptions, and most patients, after some dose adjustments, they continue. The discontinuation rate is hopefully below 20%. And we have become really familiar with the side effects of these drugs. Athena mono overall survival results was presented also within the past year, and I just thought I include that. This is another trial that failed to reveal overall survival benefit. So I still believe that when we look at the risk factors for progression of disease, these studies are markedly different, and we just have to take it for what it is. People often ask me, what's your preferred agent? And I would just have to look at individually at the patient before I make that decision. The harder decision is our HRD negative, or what we call HR proficient patients. Do we use PARP inhibitor? So we have niraparib, which is approved in this space, or bevacizumab. I think I probably was one that used a lot of niraparib before. I've probably become more of a bevacizumab individual. That's just, but there are patients for whom coming back to the clinic every 3 weeks may be an issue, and keeping them on some form of a oral agent may be easier. So I think we do have to look at the toxicity, quality of life, and what's patient's preference. What I don't advocate is omitting the maintenance therapy. I think that is something that I spend, even if the patients really don't want it, I usually bring them back once, twice, maybe 3 times to ensure that they're really making this decision in an informed fashion. Now, something that's new that's coming up, the question is, do we believe that PARP inhibitor in combination with immune checkpoint inhibitors might have a role in ovarian cancer? So this is work in progress, and I would say to you that Duo-O, Athena combo, Key-Link trial, and First trial are specific trials, almost over 4,000 patients that have looked at this particular topic. This is the Duo-O trial that was done in Europe mostly, looking essentially at arm 1, which is your Taxol carbo with bevacizumab, arm 2, Taxol carbo, bev and durvalumab, and then arm 3 is Taxol carbo, bev, durvalumab, and olaparib. And many of my colleagues are like, really, you're going to use 5 drugs to treat this cancer? You're going to break the bank account? And I get it, but I look at my colleagues in breast cancer, and they're using multiple agents, and I'm looking at my colleagues in lung cancer, and they're using a lot. So I think finding the right combo is okay, and I'm not against it. And the question is, a lot of these trials were designed with a little bit of a mistake, maybe too early, and we haven't yet arrived at the right decision. So this is the Duo-O results, which if you look at the curve that's red, that's the Taxol carbo, bev, durvalumab, and olaparib. And certainly, we can argue back and forth, is the PFS significant or not? I would say there is a hint, and the HR of 0.63 is not to be laughed at. So they've done the overall survival benefit, and they looked at the HRD negative and HRD positive, and it seems like the HRD positive patients are probably the ones who are benefiting more, and the the argument is that maybe it's the olaparib that's driving this effect. So it hasn't yet been adopted. Athena combo was looked at. This is the use of rucaparib and nivolumab versus rucaparib versus placebo. And I can tell you definitively, looking at this combination, that this is not an effective regimen. And it actually may be harmful, meaning rucaparib patients alone, they're actually better. So that's out. Now, in December, Merck made an announcement that Keytruda plus chemotherapy followed by maintenance with Lynparza, with or without bevacizumab, with pembrolizumab, did improve PFS, but it did not reach the secondary effect of overall survival. So this is the design of the trial, and don't ask me, but the second arm was pembrolizumab alone. And I think that may be potentially a problem, because that's not what I was interested in. I'm really more interested in the olaparib alone versus pembro olaparib, which is the bottom one. This was just last month presented at SGO, and it is really significant because, again, we're seeing a hazard ratio of 0.6, consistent with the Duo trial, in the combo of pembro-olaparib combination. They looked at progression-free survival. It's definitely there. The overall survival, however, is not. Interestingly, pembro alone, as I don't have to tell that, you can see this, makes no difference. So you need the combo if you're going to use this. I'm going to skip over this because I think there's going to be a lot of postmortem about this study coming up in ASCO, and I'll leave it at that. The overall survival benefit was not reached, so hazard ratios here cross 1, and probably this is going to make Merck maybe not go to FDA to get this approval. But I would argue with you that my patients don't sit in the office and ask me, can I have 6.5 years versus 6.1 year of survival? Being disease-free and having a long PFS, actually, in my opinion, as a clinician, is an important benefit. Now, again, what FDA thinks, I don't know exactly. So similarly, GSK has also announced that in the first trial, which is use of dostarlimab plus niraparib, improved PFS, but it did not improve OS. And this will be presented at ASCO, actually. So let me just skip through all of this because this is really not going to show anything that I want to talk about here today. So that's kind of where we are with ovarian cancer. I'm going to move for the next 15 minutes to endometrial cancer. So endometrial cancer staging actually changed. We went from 9 categories to almost 19 categories. What happened in endometrial cancer is that we got a lot of information that the molecular characteristic of an endometrial cancer really defines its behavior. And we have incorporated that now in the staging here as well. So, I give you an example. If you have an aggressive histology with any myometrial invasion, so if you get a serous carcinoma and you got 5% invasion, this is actually a stage 2C disease. Now, I think the people who made this decision wanted to trigger you to think about additional treatment. Because if you left it as a stage 1, it might sway you and say, well, this patient doesn't really need treatment. So the state, and there is a lot of debate within my specialty about, is this good, is it not? I would tell you this is where we are. We just have to accept it. In stage 4, for example, the invasion of bladder and rectum is categorized as stage 4A. But sometimes you have peritoneal metastasis, but not beyond peritoneums. That's a 4B. And 4C is now for patients who have distant mets like lung, liver, or bone. So I think that's an important characteristics. How do we divide endometrial cancer? So the subtypes, right away we ask the question, do they have polymutation or not? As you know, many of the institutions don't do polymutation. So the only way to get this information is actually go to an NGS company. So you have to do Caris, Foundation, Tempest, whatever your company is. Or sometimes organizations do this themselves. Then you have to ask yourself, is this a pMMR or a dMMR tumor? And then you have to ask the question, what's going on with the P53? That's how you classify, finally, a patient. Poly is really important because the poly patients, regardless of their stage, they do very well. They account for less than 10% of the patients, but even the aggressive histologies, they live a long life and they can always be salvaged and rarely die of disease. 2 major trials were published in endometrial cancer, which really has changed our practice. NRG-GY018, this is through the cooperative group, looked at additional pembrolizumab to the standard chemotherapy, and the maintenance pembrolizumab was for 2 years. The RUBY trial, otherwise known as GOG3031, was a separate trial that looked at dostarlimab added to carboplatin and paclitaxel, and the dostarlimab maintenance was for 3 years. Both of these studies were published in New England Journal of Medicine and show significant benefit for all patients who went on the trial. So this is for recurrent endometrial cancer as well as advanced endometrial cancer. So let's look at Ruby trial for a second. So when we actually looked at the various classifications and the molecular subtypes, you can look at the polymutated patients and you see that they're really doing well. You look at the DMMR population on the top right, and as expected, you see a very nice separation of the curves for patients who are getting immune checkpoint inhibitor with a hazard ratio of 0.4. But unexpectedly, we saw patients with P53 mutations. So these are your serous carcinoma, some grade 3 endometrioid adenocarcinoma, as well as maybe carcinosarcoma, that when they receive this combination, they are also getting a hazard ratio of 0.41. The patients who are not benefiting from this are the no specific mutation present population. They seem to be almost no effect in that population. This is giving us the framework for designing the next study to see what shall we do for those NSMP patients. Now, another thing that's happened is there is a couple of trials that looks at role of IO plus PARP inhibitor in the endometrial cancer setting. This is the DUO-E. I presented DUO-O earlier. This is DUO-E. Unfortunately, I'm not sure whether this is prime for or ready for prime time. And we are continuing to dig into this trial to figure out who is the specific patient who's going to benefit from this combination. The way this study was designed is that they compared the durva and olaparib arm to the control. They also compared durvalumab with control. But the study was not designed to look at the difference between durva olaparib versus durva alone. Don't ask me why. Sometimes companies make a lot of investment in these trials, but they don't ask the right questions. And so as it is, we know both of the combinations are superior to control, but we just don't know what do we do with the PARP inhibitor in there. So there is some further investigation. Similarly, Ruby trial part 2 has also looked at this. Again, it has not been fully presented, and I just leave it at that. So it seems that the immune checkpoint inhibitors have a durable activity in our mismatch deficient and MSI high tumors. And really, it seems like there are subset of populations who are now, we're understanding that they're going to benefit from this, including the P53 mutated tumors. And it is not yet clear why is that case. This is something that my colleague, Dr. Aithal, is going to talk a little bit later today. However, this study was presented and the results almost has been buried right away. So question was, should we get away from chemotherapy and only treat patients with advanced ovarian cancer with Lenvima and pembrolizumab, one of my least favorite combinations because of the side effects of Lenvima. But nevertheless, this study was reported as negative because that combination did not perform better. But I will tell you that if you look at the DMMR subset of the patients, the combo is really performing well with a hazard ratio that's significant at 0.6. And there are patients who maybe don't want to lose their hair. And I think it is a reasonable substitute. My problem is that I don't know how long the Pembro and Lenvima should continue, whereas with chemo, we have a defined 6, 7, 8 cycles, and then you stop it. So in GYN cancer, we're looking at now moving slowly into also use of ADCs. Many of you in medical oncology are using this, and you're very comfortable with it. But in gynecologic cancers, we're now seeing the effect of trastuzumab deruxtecan across the board in cervix, endometrial, and ovary, as long as there is HER2 2+ and 3+ expression. We're seeing the effect of tisotumab vedotin in cervical cancer. And certainly, we have employed the use of mirvetuximab across the board in platinum-resistant ovarian cancer as long as the FR alpha expression is over 75%. So this is an exciting area for us as we're getting more agents that are coming on, and I listed all the clinical trials that are going on. I know for the breast cancer colleagues here, they're using sacituzumab govitecan a lot, but we're actually doing a trial because TROP is expressed actually across the board in endometrium and ovary, and so we think that there's actually good information there as well. Again, I tried to make this short. I'm giving you 5 minutes back because I know you're excited for your Jeep tour that's coming up. Thank you for your attention. Sorry for the... Oh, stay there. Okay, all right. I'm going to listen to Dr. Aithal.
Well, we're going to move on to the next topic, which is case discussion. The first case we'll be discussing on endometrial cancer, and most of the data has already been reviewed by my esteemed colleague, Dr. Shahin, who did a fantastic job of putting all of these trials together and its implication. But we're just going to put it in a case format so we can take it to the clinic as to how we could apply this data. And I'll present the first case, and he's going to present subsequent case, and then we'll have a question and answer session. So again, I'm Sramila Aithal, medical oncologist from U.S. Oncology Practice in Philadelphia. And so just as a means of introduction, which I know that all of you are quite familiar with, but you do see that the incidence as well as mortality from endometrial cancer seems to be rising. Roughly about 68,000 cases diagnosed last year, and 13,000 deaths have occurred. And although the overall prognosis of 5-year relative survival seems to be pretty good for all stage, 80%, and particularly those that are early stage have 5-year survival of more than 95%, but you see that those that present with advanced disease or distant metastases have less than a 20% 5-year survival, and median age is about 63 years. Now, there's also huge survival disparities for endometrial cancer. As you could see in the bar graph here, that Black women tend to do poorly, and as a matter of fact, there can be many reasons for that. One, of course, is the late stage at diagnosis. Secondly, the transvaginal ultrasound followed by endometrial sampling for tumors, for endometrial thickness that are more than 4 millimeters, which has been the standard, probably is not really the gold standard of assessing postmenopausal bleed. One of the studies that was presented at SGO last month showed that 1 in 4 Black women did not receive a biopsy, so we're missing out a lot of these endometrial cancers. So perhaps using a universal-based approach of a biopsy may not be missing out much of diagnosis of endometrial cancers and probably overcome racial disparities as well. And I want to start off with presenting a case here. So this is a 65-year-old postmenopausal woman. She presents with postmenopausal bleeding, and workup led to diagnosis of a high-grade mixed clear cell endometrial cancer. So she undergoes total resection, which is the standard of care, diagnosed with stage 3C. And she did receive adjuvant chemotherapy with 6 cycles of carboplatin and Taxol. Now, 18 months later, she presents with abdominal pain, and further workup led to findings of metastatic endometrial carcinoma with peritoneal implants as well as bilateral pulmonary nodules. Her molecular profile, as you see here, she is deficient in MMR status. She has wild-type T53. She's negative for BRCA mutation, and HER2 is 2+. And the list goes on and on about the molecular profiling. So we just heard from Dr. Shahin just a while ago what a difference it made now with the inclusion of molecular profile in the staging of endometrial cancer that certainly has changed or shifted the paradigm in the way that we look at it. So using the Cancer Genomic Atlas, as well as PROMIS classification, that's the proactive molecular classifier of endometrial cancer, we now have, as he mentioned earlier, POLI gene, which only occurs in about 2 to 5% of all endometrial cancers, and of which 25% happen in Black women. They tend to have favorable prognosis. 5-year survival is 95% or more. We're not really clear at this time should we be using immune checkpoint inhibitor in these molecular classification of endometrial cancers. And then we have the deficient MMR status, which happens to occur in about 10 to 30% of all endometrial cancers, as well as in those with Lynch syndrome. And we've clearly seen in the data that using IO or immune checkpoint inhibitor is a game changer in these patients. And then majority of these endometrial cancers happens to be the copy number low or no specific molecular profile, or perhaps TP53 wild type, and these are low-grade tumors. They tend to express estrogen and progesterone hormone, and in some cases, perhaps just using endocrine therapy may be an option, and they also have other profiling like PIK3CA mutation and KRAS and so on. And then we have, and lastly, a small number of patients with copy number high, which happens to be the TP53 mutated patients, and these are often serous or other mixed histology tumors, and they tend to carry poor prognosis. And you could see to the right or left, the graph where you see the Kaplan-Meier graph with the PFS survival for various molecular classifications of endometrial cancers as to how they do fare, and the copy number high tends to carry worse prognosis in terms of PFS. Now, it is made it to NCCN guidelines as well as ESMO guidelines to check for these mutations, but the practical challenge happens that it's not always easy to get the results of POLI mutation right away. It may take a week or two, and then you want to know whether what's the appropriate treatment to use in such cases. But of course, if you do not have POLI, then you look for MMR status and then look for P53 status. Another interesting information is that amongst endometrial cancers, 20 to 30% of them carry a deficient MMR status. This is one of the cancers with a very high number of deficient MMR status that we know as compared to other solid tumors, and that's really interesting to note. And then, of course, a word on MMR as well as MSI. We know that MMR protein is an immunohistochemical testing, and when you have an absence or loss of function of one of the 4 MMR genes, results in deficient MMR, but deficient MMR is the cause of MSI high. So MSI high is a molecular test, and you do see some mutation that's clustering in microsatellites, typically a repeat length alterations that you would see. Now, in this scenario that I presented, metastatic endometrial carcinoma with a deficient or dMMR status, TP53 wild type, BRCA negative, HER2 2+, what would you choose in this scenario as the first line of treatment for her? She recurred 18 months later after having received initial carboplatin and Taxol as adjuvant treatment. And do you think really PD-L1 status matter? Is it relevant in this scenario? So really, Dr. Shahin walked us through all of these trials, and I just put in the PFS Kaplan-Meier graphs of all these 4 trials in one slide. So to begin with, to the top right, you see the standard landmark study, that's GY018, where you see amongst the deficient MMR status endometrial cancers who are either measurable stage 3 or stage 4 or metastatic recurrent endometrial cancers, if they had a deficient MMR status, they had a significant PFS with the addition of pembrolizumab to standard chemotherapy, followed by maintenance chemotherapy, and it was not reached yet in dMMR patients as compared to just about 8 months or so, less than 8 months for standard chemotherapy arm. There were 27% patients with dMMR status enrolled in this study. If you move on to RUBY trial, once again, you see the hazard ratio of 0.028 amongst those that got immune checkpoint inhibitor with dostarlimab added to chemotherapy, followed by 3 years of maintenance chemotherapy. They did better with a hazard ratio of 0.28, 61% is a median PFS. So again, this has a maintenance treatment with dostarlimab for 3 years. And then we have the DUO-E study, which probably did not show, I know it's a complicated trial, adding durvalumab plus minus olaparib to standard chemotherapy in this subset of patients. And it probably, in the deficient MMR status, did not show much of a benefit in adding olaparib to immune checkpoint inhibitor, but although adding immune checkpoint inhibitor with durvalumab to standard chemotherapy showed benefit as compared to chemotherapy alone. Again, it's a little complex of a study. And lastly, we have another study which was done outside of US, Australia, England, Asia, and another country, a 10 study where they use atezolizumab added to standard chemotherapy and looked at dual endpoints, both PFS and OS, and it seems to favor the addition of immune checkpoint inhibitor atezo to standard chemotherapy in the dMMR patients. So these data clearly support and have changed the paradigm in the way that we are treating recurrent or locally advanced or stage 3C measurable endometrial cancers with the addition of immune checkpoint inhibitor, although the standard has been to use pembrolizumab in most of these patients. It's also important to note that RUBY trial had 10% of patients with carcinosarcoma, and RUBY also looked at dual endpoints, both progression-free survival and overall survival, and it met its criteria of meeting both the endpoints. So it's been a certain game changer, and certainly these molecular classification has helped in the way we look at prognostic factors playing a role in clinical decision making, and that's really important. Now, another question to ask is PD-L1 status really relevant? I would say not so. When you look at the GY018 study, when looking at the investigator-assessed versus independent review, the control arm had a little bit of difference, but definitely adding immunotherapy, regardless of their PD-L1 status, did better. So we don't really need to check for PD-L1 status in this population. Now, no doubt our patient had dMMR status, but what if they were proficient MMR status? How would you change the management here? If they were MSI stable, microsatellite instability stable, or pMMR? Once again, the same 4 clinical trials that I mentioned, I have put it here with their PFS in the pMMR group. As you could see, most of the trials favor use of immune checkpoint inhibitor, particularly using pembrolizumab added to chemotherapy in the GY018 study, showed a difference in this Kaplan-Meier curve. In the RUBY trial, perhaps not so much, but nevertheless, there is some separation of curves, even if you had a deficient MMR status, and it has been approved for use in this setting. Maybe more so with the addition of olaparib to durvalumab and chemotherapy has some improvement in the DUO-E study in this setting in the proficient MMR group, and then the ATTEND not so much, as you see. Not much of a difference. I'm just going to skip the mechanism of why a PARP inhibitor added to checkpoint inhibitor makes a difference, but it definitely showed that it leads to further damage and cell death. Another study, it's not a study, it's a subgroup analysis that was presented at recent SGO last month based on DUO-E study. It looked at those that had circulating or detected circulating tumor DNA. If they received combination of both durvalumab as well as olaparib, it improved their progression-free survival, as you could see here in the Kaplan-Meier curve. This is hot off the press from last month. So in the DUO-E mismatch repair for proficient population, this is probably an addition that would benefit these patients. Now, the other question that we always want to ask, is about de-escalating therapy. As you saw that the previous trials used chemotherapy and immune checkpoint inhibitor, whichever one, pembrolizumab or dostarlimab or durvalumab. However, can we avoid chemotherapy and just use immunotherapy alone for these patients, just like we do so in our colon cancer patients? If you have a deficient MMR or microsatellite unstable patients in colon cancers, we only use checkpoint inhibitor and avoid chemotherapy. Can we do the same in endometrial cancer? Probably it's not time yet to answer that question because we're waiting the results of at least 2 other trials as I listed here. Oh, I think I moved it, okay. I'm sorry, I moved ahead of time, but this is a study, Ruby Part 2, which showed that there was benefit in adding PARP inhibitor to chemotherapy as well as immunotherapy, and it showed amongst various subgroups, whether they were deficient or proficient MMR status or in the overall population, it showed that they were leaning towards benefit with adding PARP inhibitor as well. And another word on the PROMIS classification, that's the proactive molecular classifier. It's just guiding us how we treat metastatic or recurrent endometrial cancer, looking at various molecular classification. So if you have a deficient MMR status endometrial cancer, certainly adding immunotherapy showed benefit. If you had a polymutated tumor, at this point, we really don't know whether they would benefit from adding immunotherapy, but I think it's not become the standard of care to not use immunotherapy in that setting. And then certainly if we have TP53 mutated patients, we have seen that adding PARP inhibitor and immunotherapy may benefit in this scenario. So now comes to the question of, can we replace chemotherapy and just give immunotherapy alone? So we're waiting the results of the 2 trials, Keynote C93 as well as Dominica trial, to answer the question. And as you just saw, LEAP 001 was a negative study. It did not show that just giving lenvatinib with pembrolizumab and compared to chemotherapy, it didn't do any better. Perhaps we have to look at certain specific population to tease out who might benefit with using this combination. So last year was a great year for endometrial cancer. 3 drugs that were approved, immune checkpoint inhibitors in the setting, and dostarlimab to be given regardless of their MMR status, deficient or proficient, and it's made it to NCCN guidelines as Category 1. But if they progressed on first-line immune checkpoint inhibitor, what do we have? As we have recently heard the data on DESTINY-PANO-2, we've used T-DXd in breast cancer for quite a few years now. In DESTINY-PANO-2, the endometrial subset of patients have performed really well. As you see in the bar graph, those that had a IHC 3 plus HER2 status had an 85% response rate, and even overall had 57% response rates, and those that were HER2 2+ had close to 50% response rate and improved PFS and overall survival in this setting as well. So it's been FDA approved, and in fact, it got an accelerated approval and made it to NCCN guidelines. But of course, we have a few questions to ask. If our patients have progressed on first-line immune checkpoint inhibitor, will they benefit with a second immune checkpoint inhibitor, like adding lenvatinib to IO, like pembrolizumab? We don't know that yet. Can we use just IO instead of chemotherapy? We wait the results of a couple of trials. And then those that are favorable prognostic types, like wild-type TP53 or polymutated, can we use other agents? So there are ongoing studies using selinexor, which we're waiting those results. And of course, in HER2 positive patients, ADCs. So at this time, I would leave it for further discussion later, but I'll pass on to Dr. Shahin to present the next case.
That was a great case. I just have one comment. So there was a trial, which is called B21. It was presented.
Negative trial.
Overall negative. So B21 just was published within the last year. It looked at completely resected endometrial cancer. And just like Dr. Aithal just presented, they looked at Taxol carbo versus Taxol carbo plus pembrolizumab for 1 year. And the investigators had a choice to give radiation or not. That was not really stratified. What was interesting is that the DMMR population really had a significant benefit. So going back, same case, if we had this patient, I would probably incorporate pembrolizumab in the initial regimen of her treatment when she was initially diagnosed, knowing that she was DMMR. So that's the only change that I would say, given just the results published within the last year. Great case, great case.
Yeah, I just incorporated a case that had received treatment
Yep,
prior
yep,
to the use of
absolutely.
approval of checkpoint inhibitors.
This is a case of mine I just thought, I share with you, and basically, please have a seat, so maybe I can ask you a question. 60-year-old comes to the hospital, dyspnea, she has multiple pulmonary embolism, large pleural effusion, thoracentesis was done. She actually had adenocarcinoma consistent with GYN primary. This is one of the cases where we always say, don't treat just based on a thoracentesis results, get some tissue. And so in this case, a DNC was done just to make sure we understand, is this endometrial cancer or not? And it ended up being just a polyp in there. I did not do a laparoscopy here just because the patient had multiple PE, but we ended up getting multiple core biopsies of the omentum, and the pathology was high-grade serous carcinoma. So presumably this is either a ovary or fallopian tube or a primary peritoneal cancer, and that's kind of where we started. What would you give this patient right up front, not knowing anything else about it?
Well, obviously, she has significant burden of disease, so it may be difficult for upfront resection. So this would be a case to start off with chemotherapy plus bevacizumab at this time.
And there is some argument, some of my colleagues would say, well, she just had DVT, PE, do you want to give her bevacizumab? Sometimes I say, you can skip maybe the first cycle and make sure she's fully anticoagulated, maybe she's doing okay before you move on to do this. So she was anticoagulated. The initial treatment, just as you mentioned, was neoadjuvant chemotherapy. During the first month of treating her, we actually did germline testing, which has to be done now in these patients. And somatic testing will also be done, which is why you need that core tissue. And I think 3 to 4 cycles with bevacizumab is reasonable before you consider cytoreductive surgery. And in this patient, we ended up discussing with her that we don't know yet what we're going to do, but there's going to be a maintenance treatment option. That's kind of what I said to you. Nowadays, there is also a decision, do you offer this patient HIPEC at the time of cytoreductive surgery? We have one randomized trial out of Europe that shows benefit. I think a lot of surgeons are kind of using it because it's available. I don't personally today offer it, but I'm interested in clinical trials that would really support that as an addition for the patient, because I was a big proponent of intraperitoneal chemotherapy before. So this patient ended up demonstrating that she had a germline BRCA2 mutation. And when we finished her chemotherapy, we basically decided that the regimen of maintenance is going to be a combo of olaparib and bevacizumab. I want to emphasize that when Paola-1 trial was done, bevacizumab maintenance duration was 15 months, and olaparib was 48 months. And one of the things that I see in practice that may be the cause of early discontinuation is clinicians use olaparib too early. You really need to give the patient some time to recover from their chemotherapy. And there are colleagues of mine who want to start it 3 weeks just as they just finished chemotherapy. These patients' bone marrow, as well as just their persona and individual, they just need to recover. I would say most of the trials actually looked at 8 to 12 weeks before starting that, and I would say in clinical practice, 6 to 8 weeks is a very reasonable approach before you start the olaparib. In this particular patient, Bev had to be discontinued because of significant proteinuria. One of the things that we don't talk about is fatigue. Fatigue is a real issue when using any of the PARP inhibitors. We don't measure it. And what do? We typically prescribe it. We ask our APPs in the office to see the patients, every few weeks. And patients, especially younger ones, they want to stay on these medicines. So sometimes they don't disclose that information to you. And so I would reach out to each and every one of you and say that talk to the patients about it. I usually talk about fatigue, GI, and hematologic side effects. Those are the big three. And be very upfront about it. So I want to encourage some of the things that Sammy just talked about, incorporating a better lifestyle. So exercise actually helps the fatigue in this setting. Yoga is extremely helpful in this cohort of patients. But don't forget, you can actually do dose reductions, and the dose reductions have not been shown to be harmful in this population. So again, and then one of the other things that you do better than the GYN oncologist is exploring why they're anemic. As part of their cytoreductive surgery, it's not uncommon for me to remove a portion of the ileum or the ileocecal region. And in a year or two, these patients are going to have B12 deficiencies, folic acid deficiencies, and we need to be aware of it, that it's not always just related to the use of olaparib. Any hints from you on this combo?
Yeah, I have a comment to make. I know that when patients do present, many of our patients do present with some kind of thrombosis, whether it's PE or DVT. However, if they are on an anticoagulation, I am not as much concerned about starting them on bevacizumab. I want to hear your thoughts. Would you
I have come
delay?
to become very comfortable with it, and I give it. I'm exactly like you. I basically say, put them on the anticoagulation. If they don't have a lot of right heart strain, if they don't exhibit any clinical symptoms of dyspnea and their oxygenation is all good, I'm okay. I'm ready to start bevacizumab. I'm sharing with you, this is what I see in the community, excuses that we make as clinicians where we don't use the right combo for the patient, and I think it eventually hurts the patients.
The other question or comment to make is that I know we don't have data for use of olaparib as dose escalation, but have you ever tried doing dose escalation in patients that are already pancytopenic to begin with, or multiple
So you would start basically at a lower dose.
lower dose and escalate
escalate.
as they tolerate the dose?
I honestly have not practiced that a lot, but I know in the world of oncology, many folks are comfortable with that. So mostly, I kind of make a judgment and see if somebody is not good for the 300 milligrams BID. I may start at 250 BID. I find that once I've made that decision, I rarely dose escalate. So I will bring it up that the data on olaparib has been looked at, and this is ad hoc analysis of patients who got treated at 300 versus 250 versus 200 milligram BID, that there was no difference survival differences in these cohorts of patients. So that gives me some reassurance to say, hey, it's okay, I'm not hurting the patients by using a lower dose. So this patient actually went on to have normal CT scan, normal exam, and a normal CA-125, but I had a really hard time in this patient stopping the olaparib. And I will tell you that I've incorporated the use of ctDNA as yet another tool to convince the patient that it's time to come off. These treatments are toxic, and I think the duration of the treatment can potentially result in some of those diseases that we are afraid of, MDS, leukemia, and so forth. So I begin the conversation with the patient almost a year or so in advance, and I say, hey, next January, we're going to be stopping this. And I see the hesitancy in them, and then in my 3 months after that, I bring that up again. And then that's where I find that the information on the ctDNA is really good to say, hey, this is yet one more proof that at the moment you're taking a drug without significant benefit. I will also tell you that the NRG cooperative group is actually looking at a very pragmatic trial where patients are enrolled for 2 years versus 1 year. to see whether the extra year of treatment really makes a difference or not. And I think that's the way the field should move, because we really don't know. We designed these trials a little bit at random about what the right duration is for the patient. So this patient finished 2 years of olaparib, and then 2 years after that, she showed up at one of her follow-up visits with an elevated CA-125, which triggered us to look at the CT. The CT showed multiple peritoneal lesions, 5 to 15 millimeters, with a tad bit of ascites. And so the question was, what do I do with this patient? So she's platinum sensitive. She's not on any medications. And I always ask myself the question, is this a good patient for a secondary cytoreduction? So I generally tend to select my patients for cytoreductive surgery on a second or tertiary basis at a very specific criteria. Ascites is almost always a exclusion. Once they have ascites, they're not going to be good candidates. They have to have disease limited 2 to 3 sites, and I have to sometimes put a laparoscope in, look and see whether their disease is resectable. And needless to say, the patient has to have a good performance status. Then the next question is chemotherapy. What do I do in terms of chemotherapy? I'm looking to see, I'm going to reuse my carboplatin and this time combine it with something else. I can reuse my paclitaxel or maybe nab-paclitaxel. And the question is, there's going to be hair loss neuropathy. If the patient has any of those issues, I may be hesitant to use that. And I may use gemcitabine or liposomal doxorubicin in combination with carbo. What about Bev? Do I add Bev to this combination? Well, if the patient has significant hypertension or has had previous proteinuria, am I going to run into that same problem again? But I do consider it, and I think if the patients have ascites, have pleural effusion, it's definitely a yes for me here, even if they've exhibited a side effect before. Obviously, I'm going to carefully monitor the patient. And then the harder question is, what do you do here with a PARP inhibitor? So far, I can tell you that PARP after PARP has not been beneficial. And there are circumstances where I may use niraparib in a patient who's had olaparib. And one of the things that I do is that if the patient was on olaparib and progressed, I probably will never use another PARP again. But this patient actually had 2 years of disease-free. There may be a role for it. I have no trials to support it. It's a conversation with the patient. But again, also remember the combo of niraparib and Bev is going to give you significant hypertension. So that may be another consideration here, that it's not a great combo. Comments about this? Anything?
No, it's pretty challenging. As you said, we don't have data to use PARP after PARP, and using bevacizumab in a patient with prior toxicity is a challenge.
And one of the challenges in retreatment of patients is carboplatin. Obviously, there's a chance for hypersensitivity reaction. Once the patient develops that, our desensitization protocols are very burdensome, requires long time chair and sometimes even an admission overnight to the hospital. You really have to have that discussion with the patient. Is this beneficial for them or not?
What about Duo-O in this scenario?
So the Duo-O trial, I guess, looked at the, I didn't go into that actually, but I think you're saying like add the pembrolizumab to it. Well, that trial was just presented, and I think there's a valid point to that. I'm not opposed to it at all. I think going back in this patient today, this patient is HRD. But I think that strategy of adding a checkpoint inhibitor may be really good in our HR proficient patients. So a non-BRCA patient may even derive a better benefit from it, because we really don't have great strategies to manage those patients. And I will tell you that if the patient is folic receptor 2 plus 75%, there's an ongoing trial with AbbVie called Gloriosa, that the maintenance is Bev versus Bev plus mirvetuximab. So I would encourage, wherever you are to kind of look into that. That's the only trial that I know that's looking at that sort of a combo in a platinum-sensitive patient. So I think many of these, we know that patient is not going to be curable. So we do have to kind of look at ongoing issues down the road about, mirvetuximab. That's an option for this patient. If the patient is HER2 2+ and or 3+, trastuzumab deruxtecan, just as you mentioned, is an option. We have some standard chemos, but also looking at these other clinical trials. Profound is actually now acquired by company Genmab, and Rhina-S is a clinical trial that's available. We have that at Alliance, and I've actually successfully treated some patients on that with a very reasonable response rate. The company STRO has luveltamab, and luveltamab is also using the folate receptor, but at 25% instead of 75%. And the trial just finished enrollment, and that's standard chemo. There's going to be some new data coming from the company Corcept, which looks at NAB. It's actually not docetaxel. It's a mistake on my part. It's nab-paclitaxel plus a glucocorticoid agent, and shows that that's better than weekly Taxol. And then some other trials, I put the FAETH. This is a trial that we're going to be opening up. So I'll kind of stop there. I have another case if anybody wants to talk about it, or any questions from the audience. This is really informal, and both Dr. Aithal and I would be happy to answer anything. All right. We'll probably stop here. These folks want to get on the Jeep.
Thank you. And lunch, of course.
And lunch.
Thank you both for that wonderful discussion. I would now like to invite Dr. Rejby from Creighton University to the podium to present our next session.
All right, I know I'm between you and lunch, so this is meant just kind of like a brief overview about palliative medicine and oncology. I'm now practicing at Mayo Clinic. When I signed up originally, I was at Creighton University, so I hopped over. So anyways, we'll keep this brief. Basically, just a general overview about how do we incorporate palliative medicine and oncology, the difference between palliative medicine and hospice care. It's always a big one. And then what does palliative care do for our patients that are undergoing oncology treatments? So this is one of a quote that always really sticks to me. It's from Patch Adams, love that movie as well. You treat a disease, you win, you lose. You treat a person, I guarantee you'll win, no matter what the outcome. So that's really, in the palliative medicine, and I feel, all of our physicians have that mindset. So that's really kind of near and dear to my heart. So this is from NCCN, the definition of palliative medicine. So, basically we incorporate not only the patient, but the family and the caregivers. We want to focus on managing their distressing symptoms. We also incorporate psychosocial and spiritual care based on the patient, family, and caregiver needs, values, and cultures. So usually when I meet with a patient, it's, with the family, with the caregiver, and I'm not only asking how the patient's doing, I'm asking how everyone in the family and the caregivers are doing to make sure to give them the adequate support and care that they need. So the goals of palliative care, when I meet with a patient, is really to prevent and reduce suffering as much as possible, promote adaptive coping, about kind of all these like what ifs, a lot of times, patients are waiting for these, for their markers, their tumor markers to come back. They're waiting, they found out their disease is progressive. They're waiting to see what the next steps is. A lot of that can take some time. And so, I work a lot with the patients, families, and caregivers. How do we cope during this time period? Support the best possible quality of life for patients, families, and caregivers. And then, the care continues regardless of the disease stage or the therapy needs. So this is the palliative care timeline. Again, this is also, brought about by primary palliative needs by the oncology team, right? And then it can be augmented as needed with collaboration with the interprofessional team of palliative care experts. And so this really is a timeline. Usually palliative care is initiated when the diagnosis is made, right? Maybe patients having some nausea or, symptoms like that with these cancer treatments. And so it can be also concurrent, right? And be delivered alongside disease-directed, life-prolonging therapies. That's usually when I get consulted is when, we've initiated these symptom relief medications and it's just not, patients still reporting, worsening nausea and things like that. That's usually when I get consulted. But I feel like most of the time, sometimes, unfortunately, we get consulted at the very end. So it's, the disease progression. So it's when disease-directed therapies are no longer effective. And then the discussion is that do we shift focus to be predominantly palliative care? So I get a lot of questions about, from patients, families, and along my colleagues, what's the difference between hospice and palliative care? So this is the similarities, right? Palliative care, I just wanted to make it, it's a really big circle, right? Hospice is a very small thing that what we can do in palliative care. Both hospice and palliative care, we focus on improving quality of life, reducing symptom burden, providing psychosocial support to the caregiver and families. The difference is that, palliative care is a consult, right? It's, they're coming to see me in my clinic. I'm working alongside with them to make sure that they're, most of the time their goals is to continue with cancer disease-directed therapies, right? And so my role is to help alleviate the pain, maybe improve their energy so they can keep going with the treatments, right? So it's used concurrently with the disease-directed treatments. Hospice care is when we think that really the life expectancy is less than 6 months. There was a recent study show that we tend to, in oncology, we tend to overestimate this by 500%. So it's just, sometimes I broaden that out. Maybe if you think, would you be surprised if this patient dies within the past year? That's when we want to start thinking about it, right? Bringing up those discussions. But the biggest difference is hospice care cannot be used concurrently with disease-directed treatments. So that's something I hope to change in the next 10 years. There's a lot of movement on the federal level about changing what Medicare covers with hospice care, because that's really what delineates that. But yeah, as of right now, that's what it is. So symptom management, as we're in Arizona, cactuses hurt. So, we're going to be talking about pain management a little bit. So pain management is really, this is the International Association for the Study of Pain, the definition for that. But really the takeaway is that pain is subjective, and it really is, you learn what pain is depending on, your life experiences, your cultural beliefs, and things like that. So as of right now, there's not like a troponin marker for pain and things like that. So we really have to go off the patient and, what the family's saying. And of course, you want to do well differential. This is just to kind of highlight all the different types of pain. So when I talk to my patients, I really go through all these different kinds of pain and try to figure out where they land at. A lot of times it's a mix with our cancer pain, and you can see the cancer pain at the bottom. Basically, it's everything. Everything can fall into that. So pain management, of course, there's pain medicines, there's the non-opioid analgesics, there's the opioids, and then there's adjuvant. And then there's a lot of non-pharmacological interventions, like rehab, psychosocial, and new thing, there's like neurostimulation. You can also do integrative, like acupuncture and things like that. Interventional, it's going to be more of like a nerve block and things like that. So this is kind of, NCCN, when they updated their guidelines about palliative medicine, this is one of the major things that they updated. So I, wanted to kind of go more in depth with this with you guys today. So anorexia, cachexia is the loss of desire to eat. This, basically it can go, can occur independently with the pro-inflammatory cytokines and tumor-derived factors directly lead to muscle proteolysis. So it's a lot of different things that play into why, our patients are unable to eat. And cachexia leads to asthenia, which is, weakness. And this is associated with failure of anti-cancer treatments, increased treatment toxicity, delayed treatment initiation, early treatment termination, a shorter survival, and psychosocial distress. So this is something that we really, want to be on the forefront to see how we can best alleviate this as a, as a interdisciplinary team for a patient. So a lot of times, head and neck cancers is kind of what we see a lot. But for any patient going through cancer treatments, they can have dysphagia symptoms. And for that, I always put in a formal swallow evaluation to see what's going on. And you can see there's a lot of things that can be associated with this, right, that we can treat. Oropharyngeal candidiasis, I feel like that's kind of the major one that you see, especially when patients are on steroids concurrently with their cancer treatments. But you can see it's a whole host of different things. And sometimes if we try to treat the underlying cause, the anorexic cachexia can get better. But it is complicated. I'll lay that out. But these are things I'm really diving into when a patient says that, this is a major problem for them. So, treatments tend to be non-pharmacological. So, you can send your patient to a speech and swallow, and they do swallowing exercises. It might be a little bit different, eating habits, feeding assistance, appetite stimulants, megestrol acetate. Sometimes I've seen where this is added. I would really advise caution with our oncology patients just because it does increase the risk of venous thromboembolic events, fluid retention, and death with our oncology patients. So it's pretty drastic. It's about 15%. It can cause a blood clot. So dexamethasone, has a whole host of side effects that we're aware. Olanzapine tends to be the one I stick to because it has a pretty low side effect profile with the medication in and of itself, and you can see results within a 4 to 6 week if it's effective. And so, this is just kind of like, the iceberg, tip of the iceberg of what we address when we're doing a palliative medicine consult, but we address a whole host of other symptoms. My consults tend to last at minimum an hour, so I ask a lot of questions. Another thing that we do, this is more with my interdisciplinary team. I have, a social worker, I have a nurse, I have a chaplain dedicated to my patients. So we do a lot of coping and social support with our meetings as well. So this is more of like when my social worker meets, but I tend to cue in part of our Edmonton's symptom score assessment, which is the standard when we do palliative medicine. It asks them about their financial distress and things like that. So it kind of clues me into if someone needs to go see our social worker. But what our social worker can identify is, how they're coping and adjustment to their illness, any financial resources we can tap into, any culture-specific needs, caregiver ability, what the costs are for these things, and then transportation access. So social interventions, there's a lot of different things that they can do and we can refer to. And the next thing that I tend to do is towards the end of my meeting is advanced care planning. So the definition is that the process that supports adults at any stage of health in understanding and sharing their personal values, life goals, and preferences regarding to future medical care. So the goals is that when I'm doing advanced care planning, it's proactive and ideally not reactive. We're trying to see, where they're at, in the current state, but also what are their hopes and wishes are, and what are we worried about, and having a plan for all these different scenarios. You want it to be appropriately timed, and you want it to be integrated in routine care. So you do want to, obviously it's not going to be every visit that you see the patient, but, probably once a year, just checking in and just saying, hey, if there's any changes with this, and what do we need to talk about. The pros are, studies time and time again, patients do want to know the bad news. A lot of patients, they find a lot of with their grieving with the bad news is that they do a lot of planning for things, and patients always get a lot of significant value in their life when they do the death planning. So we do, as much as it breaks everyone's heart, including mine, I unfortunately, sometimes I see this a lot, we do want to be honest with them. And, and also another thing that I see time and time again is that, a lot of times patients are confused about whether treatments are palliative or curative intent with their oncology treatments. So, really being, honest, what do these two things mean, and going in detail about that. So a lot of times patients are confused. So in conclusion, ideally we want to get early palliative care involvement. Obviously depends on your institution resources, but many guidelines, including ACS, ASCO, and NCN, recommend early palliative care for patients with advanced care. And this could be primary palliative care and then stepping up to specialty if needed. So there's a lot of benefits to getting palliative care involved. We do symptom management, psychosocial support, and most importantly, can be used concurrently with cancer treatments. And then also instituting advanced care planning early and having it routine. But like I said, it kind of depends on the patient and the prognosis of things. And this just ensures the care is aligned with the patient preferences at every stage, including success. Any questions? Yes.
So, like with olanzapine, how do you compare that with Remeron versus
So Remeron, the studies show that it really only helps the patient when it's associated with depression or anxiety. Olanzapine, it can be purely just, anorexia, cachexia. Yes.
Would you use the 5 or the 10 milligram dose? Some patients have recurrent nausea and vomiting.
Yeah, no, great question. So if the patient has nausea or vomiting, you go the 5 milligram dose. If we're treating purely just anorexia, cachexia, you can actually start as low as 2.5 milligrams, and that's at nighttime. And there's been proven benefit to that. Yeah.
What are your thoughts on medical marijuana?
So medical marijuana, it's really, I say it's like my third or fourth line. It's not the first one I go to because there's no large evidence-based trials in it yet. It's really anecdotal, do my patients have benefit to that? I just worry about the geriatric population. There's a significant burden of psychosis with medical marijuana. So I always say, like, if you're going to, like a cannabis home, whatever they're recommending, half that. And then, I try that out for a week or two. And then if they start getting the high sensation without whatever the benefit is, so a lot of times patients use it for nausea, insomnia, pain relief. If they're not getting that benefit but getting the high sensation, then I advise them to get off of it. Yeah, but great question. Yeah.
Is there an option for non-narcotics in control for patients who cannot tolerate or don't want to take narcotics and cannot use NSAIDs? What are your go-to for pain?
Yeah, so it's tricky. There is a new drug that's coming down the pipeline that just was FDA approved. It's extremely expensive. I think it's $3,000 for like 2 pills or something like that. So we're not quite there yet. So, but one of the ones that I like to do is a Butrans patch. So it's buprenorphine mixed with naloxone. It tends to have reduced constipation side effects, and it comes in low as a 5 microgram dose. So really, if you, it's equivalent to a patient taking Oxy 10 milligrams once that whole day. So it's a really low opioid. And so I tend to patients who are kind of hesitant about starting an opioid, so you can actually start an opioid naive patient on that with the Butrans patch. Butrans patch tends to, it's kind of 50-50 whether insurance is like that, but it's an option. Other times, you can just do really low dose morphine. Morphine is usually always covered by insurance. So you can do 2.5 milligrams of morphine. So I call it microdosing is kind of how I discuss with patients. And just to kind of, for them to see if they get any relief and things like that. Nerve blocks are another good option, kind of the tried and true pancreatic cancer, but you can do it for a whole host of different things. It tends to have to be localized. If it's localized to 2 areas, you can probably do it. But if it's kind of full body pain, then it's a lot of discussion of, okay, like what are our goals with the pain management? Because a lot of the pain medicines are sedating, and that includes like gabapentin and Lyrica too. So it's really a discussion and, you know, and trial and error, unfortunately. I wish I had like a genetic swap I can do to see, you know, what they're more susceptible for. Yeah. Any other questions? All right, thank you guys. These are my references.
Okay, we are about to break for lunch at this time. We are going to have you go visit the lunch buffet next door and then come on back in for a session by Regeneron. I did want to let everybody know that we do currently have 2 spots left available for our Jeep excursion tour today. We are getting to the point where we have to get waivers filled out. So if you haven't filled out your waiver, be sure and stop by the desk and fill it out. And if you are able to attend and would like to go, it's first come, first serve to grab those 2 slots. But please go visit our registration desk and sign up. All right, we'll be back in a few minutes.